I'm delighted to be presenting to you all Dr. Stephen Hoff. He's Associate Professor of Otolaryngology at Northwestern University, Lurie Children's Hospital of Chicago. He started his medical career in Chicago, getting his MD at Rush before completing residency at University of Illinois Medical Center. And in 2010, he came to Stanford as our Pediatric Otolaryngology Fellow. He was an awesome fellow. Because of our common interests in otology, downhill skiing, and mountain biking, I'm not sure in which order, we became very close during this fellowship as well as afterwards. After graduation, he returned to Northwestern, where he has built a vibrant pediatric otology practice and has made himself known as one of the worldwide experts in endoscopic ear surgery. And because we tended to always meet at the same meetings, I've seen Steve give many, many great talks and thought he'd be great to invite here to Stanford Grand Rounds. One thing I noted on his CV is that in his 9 years on faculty at Northwestern, he's gotten outstanding teaching awards 4 of those years. This doesn't surprise me at all because all of us here at Stanford noted immediately that he was a fellow with great skill at teaching and thus was really well liked by our residents. The final thing I want to highlight is that each year, the largest, most well-attended meeting on endoscopic ear surgery is the World Congress on Endoscopic Ear Surgery. And in the most recent meeting in 2019, he won 2nd place for his presentation, Endoscopic Congenital Cholesteatoma. So with that being said, I'm sure during this talk, he's going to have a lot of useful pearls about endoscopic ear surgery to show us, and I'm really looking forward to it. Thanks, Steve, for coming.
Thanks, Kay. It was a great intro, and certainly this would be fun to do in California. And most of my talks, of course, are I'm used to doing in person because they rely a lot on kind of interaction, and I show a lot of videos. So I do hope those show up, but I'm excited to talk about some pediatric endoscopic ear surgery. It is a bit of a controversial topic. I was thinking maybe we could start by maybe voting, maybe one side blue, one side red. No, just kidding. We're not going to do that.
Please.
As far as endoscopes and microscopes, but I really don't want to pit endoscopes versus microscopes. This is really what the endoscopes are kind of capable of, how they can help with ear surgery. Certainly those two modalities are not mutually exclusive. They can be used together. And I think they can really help our patients. Here's my disclosures: educational consultant for Carl Storz and travel grant for Med-El. I figured I'd throw in a picture from a fellowship. This is Peter Koltai, of course, probably wondering why I'm taking pictures and not operating, but it was very fun to be there. I did try to look for pictures of Kay and Alan, but all I could find was pictures of us skiing and snowboarding. So that kind of sums up, I think, the fellowship I had. But then I did come back to Chicago, which is where I am sitting now. And it's a beautiful place, kind of on the lake, and took what I learned from fellowship back to Chicago. But one of the things that we didn't do a lot of in fellowship, because nobody was really doing a lot of it, was endoscopic ear surgery. In fact, if you look at this chart by the endoscopic ear articles by year, there's a huge explosion in the last 10 years. That entire uptick is in the last 10 years. Of course, people were doing this before 10 years ago, but the interest and the outcomes and the research and the techniques have really evolved just in the last 10 years since I was a fellow. And it's easy to see why. You know, when we look in with the endoscopes, you get this nice, dynamic, high definition view of the middle ear, of the pathology. This patient so happened to have a subtotal perforation, which certainly makes it easy to look in. But, you know, you can use the endoscope to look in the ear canal, palpate the ossicles, really get a close-up view of the pathways within the middle ear, which I think is not only a great way to visualize, but also to operate in the ear. It also, you know, is really interesting because nothing in the middle ear is new, but it really brings in things that you don't typically see, or at least when you're learning otology, because this is really great for our residents and fellows. Things like the ponticulus and subiculum and funiculus and fusus, these are things we see in most cases. And so all these little nooks and crannies in the middle ear are just fantastic to see. I like this little sketch. So Dr. Marchione, this was my prize for winning that 2nd place that Kay was just saying. He did a hand freestyle sketch of the middle ear endoscopic anatomy, and it was pretty cool. If you zoom in really closely, you can even, this video I think stopped, but you can even sometimes see capillaries with red blood cells kind of running right in it. So clearly you're getting a really close-up view, which certainly is a different perspective than the microscope, even if the anatomy itself hasn't changed. Here's an example of a facial nerve that's dehiscent with the capillaries there too, with a missing stapes after cholesteatoma surgery. So this is just a view that allows you to see further into the ear, which everybody kind of wants. This is kind of one of the fun parts. Everybody wants to watch. You can see my fellow operating, the residents watching, the tech is watching the screen, and even the anesthesiologist is ignoring his two screens and watching our screen, watching us operate. So it really does offer a nice kind of perspective on the ear. But when it comes to endoscopic ear surgery, I feel like it always starts there. It starts with the oohs and ahs and the shock and awe of what the endoscopes can see. And I think, a lot of those articles are booming because there's a change in kind of what we're thinking. Not only what advantages do we gain, but when are they not appropriate? How do the outcomes compare, endoscopic versus microscopic? And do they kind of change our entire thought process on otologic surgery, on what we can do through a transcanal approach? So it's kind of time to move beyond just the Nido visualization that we get, and how can that really help us, and when should we be wary? Now, the endoscopes themselves are, of course, not new. In fact, at the American College of Surgeons, which is essentially across the street from where I'm sitting, there's the replica of the Bazzini Licklighter, which means light conductor, built in 1806, which was considered the first endoscope. A candle would sit in that large black portion with the endoscopist's eye looking in the eyepiece. The candle would provide light, and you can see a smoke evacuation chamber at the front. So certainly we've come a long way. I know Peter and Rob Jackler have a big interest in the history of otology, and so do I. And it's always fun to see kind of where we've come. And then endoscopes for ENTs are certainly not new either. Laryngoscopy, rhinology have been using endoscopes for quite a long time. And so one of the questions is always, why haven't we been using these for otology? And of course, the quality in endoscopes, getting in that small space, has vastly improved over time. To current date, where we're using 4K endoscopes with angles and sometimes 3D visualization, to the point where it's truly viable. The light sources are truly able to cast light on all those small recesses within the ear. And of course, the major advantage being the viewport. So microscopic view, you're reliant on the light being able to go directly up the speculum into the microscope, whereas the endoscope kind of has a broader viewpoint. And of course, you can use angled endoscopes around corners and really be able to get that transcanal view. Here's a view looking at the stapes. You can see the ponticulus there, able to palpate, look straight into the sinus tympani. This is with a 30-degree endoscope. You can use even more curved ones in order to get really into those deep recesses. So for this discussion today, and in general, we're going to be using what we call TEAS, which is transcanal endoscopic ear surgery. And there's a classification system developed by Mike Cohen and the group at Mass Eye and Ear, Dan Lee, where it's kind of what type of instrument or what technique did you use to do the case. And so TEAS is endoscope only. This goes from using solely the microscope, class 0, to a mixture, class 2, or class 3. So most of what I'm going to talk about today is what can the endoscopes do. I certainly use the microscope all the time, not only for cochlear implants, but for many cholesteatoma cases. They have a real and long-standing role in otology, but this is kind of about what the endoscopes can do. So the first bullet point was on advantages. And so what can we get? We can get wide dynamic visualization. We saw that. Another thing to take into consideration is the heads-up procedure. So this procedure is done while watching a screen. It's easy to get into kind of a bad posture position during otology using the microscope. Not always, and that's part of training, but it has been reported. In fact, there's a recent paper on kind of the hazards of being an otologist with the neck and back positioning. This is considered minimally invasive surgery, so it meets the criteria for minimally invasive surgery, which is because there's decreased post-auricular dissection, there's no incision and closure, no mastoid mastoidectomy and mastoid drilling if you're not using the microscope, which can lead to decreased operative times with after the learning curve, that is, with training, and potentially decreased pain and increased quality of life measures, which we'll talk about in a bit. Another interesting thing is its direct access to disease. So, cholesteatoma, tympanic perforations, these are diseases of the tympanic membrane and middle ear, and this is directly accessing that space without going through potentially normal tissue, post-auricular or through the mastoid to get to that space, which in my experience as a pediatric otolaryngologist really leads to high patient and parent satisfaction, which I've not done a study on, but I certainly get that feedback a lot. The parents are very appreciative that they can't actually see an incision. And we'll get into what are the main disadvantages. And the real question is, how do the outcomes compare? Not just how are the outcomes for endoscopic ear surgery, but is this a legitimate technique, and how do they compare to microscopes? Now, when people get started with endoscopic ear surgery, you can see why it's immediately kind of abandoned by many. This is an early case. This is a resident, or maybe even me, doing an early case where it's just there's blood, you can't see a thing. It's smudging the scope, and it can be a frustrating learning curve. And besides the bleeding, it's a one-handed surgery, which is not a typical otology experience. There's potential trauma to the ossicles by bumping into the ossicles physically with the endoscope itself, and thermal damage to the facial nerve if you don't watch what your light settings are for the endoscope. But these can be controlled. For bleeding, there's lots of things we do. I do patient positioning with a reverse Schindellenberg and kind of a flat head, or the head horizontal, I mean, to get the blood away from the ear. Using epinephrine pledgets, using gel foam, just using irrigation. And there's plenty of ways to mitigate this bleeding so that it just isn't as much of a factor. When you go to endoscopic ear surgery meetings, especially the early ones, it's amazing how many talks and how many portions of everybody's video are just about them raising a flap. Which is interesting for a bit, but it is kind of one of these things where once you mitigate the bleeding factors, it becomes not as much of a discussion point, much like microscopic surgery, where the flap itself is not the case, but it is part of the big learning curve there. Suction instrumentation can help too. This in particular is a suction flap knife that can help with bleeding during the raising of the flap. It really helps too with our residents and fellows. I mentioned the heads-up approach. We use this in the lab with fresh frozen heads, as well as the temporal bone lab, and in the operating room. And most residents and fellows are very experienced with endoscopic sinus surgery and other endoscopic techniques, laryngology. So this is not necessarily a new thing. And in fact, the learning curve itself may be a bit overstated. There's a study that came out just this year on teaching microscopic ear surgeons their first 25 endoscopic ear cases, and a naive ear surgeon who does their first 25 endoscopic ear surgeries. And essentially, the operative time itself was the same. So the learning curve may just be that it's a learning curve with instrumentation, but people who are used to doing endoscopic surgery when the sinuses really pick this up quickly. This is a third-year resident doing their kind of very first ossiculoplasty. You can see it gets dropped a few times, gets put on sideways, but eventually gets to the right spot. And what is one of the harder things to do with endoscopic ear surgery can be achieved even in a kind of an inexperienced surgical hands. So I'd like to go through some different examples of of ear pathologies and where the endoscopes can be used and be helpful. starting with congenital and traumatic conductive hearing loss. So either a congenital conductive hearing loss from vesicular malformations or traumatic vesicular disruptions, and how these endoscopes can help. I think this is a particularly useful application because through a transcanal approach, you can see that entire vesicular chain and usually intervene. Here's an example of a congenital malleolar fixation with a posterior bony bar that follows the chorda tympani, which after the TM flap is raised can be divided. In this case, too, there was congenital incus anomaly, which was the incus was non-viable and removed, and this can be reconstructed with a PORP right there on the stapes. One more example of a traumatic vesicular disruption. This child actually stuck a Q-tip in their ear, ruptured the TM, which then healed. But when we went in, because of a maximal conductive hearing loss, you could see that the incus and stapes have a large gap between them. And it also gave us a great view of the middle ear. We could identify that gap and then close that also with a PORP. That was a little too far away for the synthetic bone cement. It really was. A PORP was a better option there. When I looked at this in 2017 with our own patients, so kind of our first 20, we've done many more since, but we did see that in general, we saw an improvement in hearing after this through that transcanal approach, which means, you know, it's a viable approach to be able to access and treat the disease. So one of the more common, I guess I say starting cases, but that doesn't necessarily mean it's easy for endoscopic ear surgery are tympanoplasty. These can be great cases to kind of get your hands wet, certainly before cholesteatoma cases, all the way from doing paper patch to fat graft, although I usually would use the small otologic microscope for that, to any type of underlay graft or push through graft or inlay graft or over under or bucket handle or any kind of name of a graft you want to come up with. And lateral grafts are possible too. And I'll show a video of that, although those aren't quite as fun. My go-to these days are the cartilage shield graft or perichondrial island graft. I will typically freshen the perforation, get a large tragal graft and stamp it with a speculum, and then design the graft, take out whichever cartilage is needed to take out in order to close the hole. This is a large one. This is basically a full shield, but very often we'll use a half shield, just a half a semicircular, just a semicircle that is, or 3/4, or kind of to tailor that to whatever the patient needs. And then you just kind of slide it in underlay fashion to close that perforation. I found that the cartilage is reliable. I'll go over some results in a minute, but you know, using fascia, temporalis fascia, or very often the tragal perichondrium or a xenograft, I do find that the cartilage tends to be more reliable and more consistent results, which from tympanoplasty, which is in most cases an entirely elective procedure. So it's not life-threatening, but certainly expectations are high because it's an entirely elective procedure with you know, you can't really hide from an audiogram. So there's a judge at the end, which is the audiogram, that will tell you whether or not you were successful in closing that perforation. The goal would be to do this once, and I found that cartilage is reliable there. I've done a lot of the butterfly grafts with the endoscopes too, and this is something that comes up quite a bit. Fairly easy. What I do is you know, you measure the hole, and then you can use a dermal punch. In most cases, unless the hole is too big, but you can use a dermal punch to get a rim of cartilage from the tragus that's 2 millimeters wider in diameter than the hole itself, and then just carve the circumferential notch and just lock that in, kind of like an ear tube, so to speak. And sometimes it just locks in right away, and sometimes it takes a little bit of manipulation, but it can look really nice afterwards and get closed. And most times these patients do not require packing or much postoperative care, essentially, aside from just keeping their ear dry. So these can be very satisfying. I will say that I've noticed a lot of residual perforations right along the edge of the cartilage, which is a little difficult to close because you can't just, you know, put a patch there. So I do find that the underlay cartilage is a little more reliable. And like I said, lateral grafts are possible as well. They're harder with the endoscope. The advantage being here, you don't have to do a canalplasty for visual access, although you may still want to do a canalplasty of the anterior canal wall to prevent blunting of the anterior canal wall. But a fascial graft can be inserted. There was a shot earlier of kind of getting in that correct plane. Fascial graft, which is just pulled up on the malleus with an alligator's tucking a little bit of gel foam around the annulus and replacing that canal skin, which is taken off at the beginning of this video. So lateral grafts certainly are doable. I wouldn't say they're particularly the endoscopes are particularly better for them, which is to say I'd rather have two hands for that in most cases, but have had some success there. This is the patient. In fact, this might be two different patients, but this is closing the perforation with a lateral graft for the postoperative outcome. Looking at tympanoplasties when it comes to postoperative outcomes, there's plenty of literature on this. But when it comes to just, when we look at a meta-analysis or just a combination of multiple endoscopic tympanoplasty papers, the closure rates are good. So ranging anywhere from 84% to 97%, which are good closure rates. And these are essentially equivalent to microscopic rates. In the paper out of Toronto, they found the same thing, that their tympanoplasty closure rate endoscopically was 85%, and with the microscopes it was 89%. So essentially equivalent. So this would just indicate that the endoscopes are a viable tool, and they can get equivalent rates of closure to the microscopes. In our own study, or at least looking at our own data, out of 187 patients, 86% closure rate, with a much higher closure rate with that cartilage shield, as I was mentioning, and lower as you go down to the perichondrial underlay, butterfly graft, and the xenograft, which would be usually the Biodesign graft, which handles very well and is very nice to have, but I find the cartilage to be a little more reliable. So endoscopes certainly do a good job of closing perforations in that transcanal way. So what benefits do they offer? Well, just that is a transcanal surgery. It's a minimally invasive surgery. So if we can get equivalent rates of closure, what else are we gaining with the endoscopes? In a study last year, looking at the GBI, Glasgow Benefits Inventory, Quality of Life, comparing endoscopic ear surgery to microscopic ear surgery, they did find that the scores for endoscopic ear surgery postoperatively were higher. So 28 in the endoscopic group, 16 in the open microscopic group. These are adult patients, but just an indication that postoperatively, these patients are faring quite well using the endoscopes. And what other benefits can we gain? So pain. So this is a study out of Japan. In fact, this is the group that's going to be hosting the next World Endoscopic Ear Conference, which is now deferred to 2022. But they were looking at their pain outcomes comparing TEES to microscopic ear surgery, and did find that the pain requirements and NRS scores, patient-reported scores, were less with endoscopic ear surgery in the first postoperative week. You can imagine this is predictable because the minimally invasive approach and not going through a postauricular incision. I don't think anybody would argue that incision is particularly invasive or difficult to deal with, but certainly with our pediatric patients, they do appreciate that approach. So switching gears a little bit to congenital cholesteatoma, this is what I think is probably the best application in the endoscopes, because this disease resides mostly in the middle ear. It's accessible. These are usually smaller children, less than 10, that the endoscopes can really provide some advantage there. Here's an example of a Potts stage 1 congenital cholesteatoma contained in that anterior superior quadrant, very typical, which after the flap is opened and then peeled down off the malleus, the pearl of cholesteatoma can just be removed, transcanal flap replaced. In fact, that's kind of how I designed the flap for a congenital cholesteatoma, where you where you alter the flap and bring it more anterior, kind of from 3 o'clock anteriorly to 6 o'clock posteriorly, flip it down and just kind of use usually a cup forceps to pull it and kind of deglove the malleus, usually just down to umbo, but sometimes all the way, to expose that middle ear and especially that anterior superior quadrant. Here's another example. A little interesting because this is 2 pearls in the same space. Flap is raised. Suction can be used to kind of tease these out, or if that doesn't work, kind of right angle pick or whatever instrument will get you to just pop these out. And ideally, these remain encapsulated and can just be removed one at a time. And then again, the flap can be replaced. Typically, the only packing in these cases is around the edges of the flap incision itself, depending on how the dissection went. So bigger cholesteatoma is possible as well. So a stage 3 with vesicular erosion, transcanal approach. Again, the flap is raised off of the malleus, kept on the umbo to expose the middle ear. The cyst is removed. These sometimes have to be removed in kind of a piecemeal fashion, but keeping the cyst intact as much, or the capsule intact as much as possible. And then the ossicle is reconstructed. We have a post-operative video in clinic of this kid with a good result. You know, if you look at the upper left, you can see that this is filling the entire middle ear. You can see why this is very often mistaken as acute otitis media. It's a bulging white tympanic membrane. So these kids sometimes get missed. If you look very closely, you can see a small arc of aerated middle ear in front of the cyst in the top left picture, which would indicate that there's air in the middle ear and it's actually not pus. But once that's removed, we can see in clinic that you can actually see the prosthesis through the tympanic membrane, and you can see how his other ear compares. And he had a good hearing result as well. We had an interesting case also a few years ago of a bilateral congenital cholesteatoma. This kid actually came in, is a 4-year-old. He came in for a tonsil eval for snoring. And when I looked in his ears, we saw cholesteatoma in both ears. Small one on the right and a large one on the left. It was a stage 3 on the left. Actually, stage 2, sorry, because his ossicles were intact. But smaller one on the right with normal hearing. And the decision was made, his mother actually was a surgeon as well, to do a concurrent resection. So basically take out the small right side first. And if no packing was needed, which it wasn't, here's after resection, then go in and take out the left side, because I did think I would have to put packing on that side. So you can see the cyst exposed, removed transcanal endoscopically, and then the flap replaced back down with no packing needed. Going to the other side, making the canal incisions under the same anesthetic, flipping the flap up, exposing the cyst. This is then removed with the endoscopes, but the endoscopes in suction, but in piecemeal fashion. Had to kind of break apart the capsule a little bit and kind of get a suction in there to decompress the actual cyst. And then you kind of collapse the cyst and then take out that capsule and then expose the ossicles to assess them. Kind of a time lapse, different timestamps there. So this is his pre and post-operative result. You can see that with the endoscopic techniques, we were able to take out both cholesteatomas endoscopically, concurrently, I mean, and have a good hearing result afterwards. Kind of just lucky itself that the ossicles weren't eroded, but currently he's 5 years out and doing well. So we know the cholesteatomas can be taken out endoscopically. But it's more interesting to look at kind of what outcomes we get once a large volume of congenital cholesteatomas has been done. In the original staging system by Potzik, this is the one from 2002. When we look at the stage 1, 2, 3, and 4, 1 and 2 being just different sizes within the middle ear, 3 eroding the ossicles, and 4 into the mastoid. The recurrence rates are 14, 33, 41, and 67. So these are going up quite a bit as the disease gets larger, as you would predict. We are currently doing a study. We are collaborating with Sick Kids in Toronto and University Hospital in Verona to look at our congenital cholesteatoma series, and currently have 60 patients. These are only the ones that were taken out stage 1, 2, and 3, and then there was a single stage 4 that was able to be kind of pulled down into the middle ear. But these are only the TEAS patients, the endoscope only patients. And we did find that the endoscopes were viable for pretty much any patient up until the point where the disease goes past the lateral canal. In our series, most of the patients actually were stage 3. About half were encapsulated, half infiltrative. These patients went all the way down to 18 months of age with a average age of about 8 years and average follow-up of about 4 years. And we did find pretty good results. So the residual disease for stages 1 and 2 was 0%. 4 was also 0%, but that was just that one patient. For stage 3, there were several patients with residual disease, but only 7.4% in total. Now, 5.9% of these patients did have a retraction postoperatively, so this would not be residual disease. This would be a retraction that developed after manipulation of the eardrum. So after you've removed the cholesteatoma, there's some kind of damage or healing that happens on the eardrum. And a lot of these kids still have inherent eustachian tube dysfunction as well. They're very young. And so several of these patients were noted to have retractions. But overall, the residual rates were very low, and the hearing results were good to it. The majority of patients having air bone gaps less than 20. We also found that the recidivism risk, so what factors during the resection of congenital cholesteatoma makes it more likely that you're going to have residual disease. Fairly small numbers, but able to get some statistics using odds ratios, finding that particularly advanced stage, of course, stage 3, that is, open disease with cholesteatoma spilling out, erosion of the stapes, and then using the Modena bleeding score and the inflammation score, that the higher the rate of inflammation and higher degree of inflammation and bleeding, the higher the risk of recidivism. So congenital cholesteatoma are very fun, and I think a wonderful application of the endoscope. And I say fun because it can be like that case with the pearl where you are peeling down the tympanic membrane, taking out the pearl, and just putting things back and watching it heal. Acquired cholesteatoma is an entirely different beast. In fact, a lot of these, present after years of drainage or after years of referrals or drops or whatever it is. We tend to get quite a few, at least here, of advanced acquired cholesteatoma, usually primary cholesteatoma with acicular erosion, as you can see in a couple of these examples. Compared to congenital cholesteatoma, it's much messier. So acquired cholesteatoma tends to be more inflamed, part of the pathology, less encapsulated, tends to be a bit like a bomb went off when you lift up the flap, and it's a bloodier, kind of messier case. It's entirely doable, or usually doable with the endoscopes, and entirely possible to get the bleeding and the cholesteatoma out. But of course, this should probably not be the first case you try, and does require some patience and has that learning curve there. One of the advantages of using the endoscopes for acquired cholesteatoma is you are still accessing the disease where it starts. So cholesteatoma is a disease of the tympanic membrane, essentially. It has retracted in, it's been pulled up, it's collapsed, there's skin cyst being trapped within the middle ear, going up into the attic, going into the antrum. Very often when we get imaging in these patients, the mastoid is going to be opacified, but it is difficult to tell what that is. Is that more cholesteatoma? Is that a fusion? We don't know. But by going in with the endoscopes, you can kind of tackle the disease from where it starts. Take a look. Clearly, this disease is going superior. Here, the flap is up and a lot of disease has been removed, and we're dissecting it away from the stapes. As I said, these are a little more inflamed and bloody, but you just kind of irrigate that out. That disease is taken out, and we can get the blockage of the attic out. And it turns out everything in the mastoid was just mucoid effusion, which is great because we were then able to complete the resection transcanal using an atticotomy, as you can see, just reconstruct that attic, reconstruct the eardrum, and this patient did get a second look, but was able to spare them from the mastoidectomy by getting to the disease where the disease started. Also applies to secondary acquired cholesteatoma, which would be, here's a patient with a perforation, some built up keratin, an example of when the keratin has been removed, kind of the residual perforation, but if you look posteriorly, you can see you can still see white behind the eardrum, which is cholesteatoma. And we see that here, the flap is up, cholesteatoma is stuck under the flap, which, you can see chorda tympani there, IS joint, round winter niche. And the cholesteatoma is resected out, the flap entirely lifted off the acicular chain, and was able to be completely removed. The malleus and stapes stayed intact, so did the chorda tympani. Obviously, this eardrum needs some reconstruction, so we do the same cartilage shield graft typically as with a tympanoplasty, as I already showed, lay everything back down and probably get a second look too. But you can see we can get to that disease from a transcanal approach. Same thing with the posterior superior cholesteatoma with the middle ear effusion. We can see that the fusion's gone and now the anterior middle ear is aerated, and that cholesteatoma can be kind of teased into the middle ear from the attic and from the acicular chain, although she did have some erosion here of the IS joint, which needed to be reconstructed. For this patient, we put an Applebaum prosthesis on after kind of clearing off the stapes. But it's a good view of what we can see with the endoscopes, what we can take out, and what we can kind of reconstruct, again, with that cartilage graft. One of the real advantages, of course, is looking around the corners, typically using curved instruments. There are specialized instruments for endoscopic ear surgery. I am not going to be going into all of them here, but here's an example of a kind of a double curved instrument, which looks very much like a frontal sinus instrument that can be pulling the disease out from the antrum. You can see there's lateral canal and facial nerve. And so this is actually a disease that's just past the lateral canal. We can see it with an angled endoscope. We can see it with, or we can get to it with curved instruments and get to it with curved suction, and then look all the way up into the mastoid and antrum through the middle ear. There's a little party trick in this one where there are no stapes crus. You can actually just pass that pick right under the stapes. So I did a reconstruction there as well. Here's another same case where you can see the lateral canal after atticotomy is accessible. And, these helps. This is a patient who was sent to me after their first stage for revision stage, and this helped kind of figure out what was going on. There was a porp, but it was sitting on a stapes that didn't have crura. So got rid of that, got rid of a pearl of disease that was sitting directly on the facial nerve, both with some cup forceps and suction. And you can see we can get a really clear view there of what's left there. Not much else as far as residual disease, but that porp wasn't working, dropped on a interpositional torp, and we're able to position that so that both restored her hearing and kind of cleared her ear for a second stage. So when it comes to acquired cholesteatoma and endoscopic resection, there's a lot of talk now on what we call functional endoscopic ear surgery. FEAS is an acronym that's already kind of been taken, but we can think of this very similar to functional endoscopic sinus surgery. And looking at the middle ear as a nasal sinus. So, the eustachian tube connects directly to the middle ear cavity, and the ear ventilation pathway going from eustachian tube, middle ear to attic, antrum, and mastoid, typically via the tympanic isthmus. and then using the mastoid mucosal gas exchange. And these two different major sources of gas modulation really kind of maintain that aerated middle ear. So one of the main goals, very much like doing a FES in the sinuses, is to kind of restore those natural aeration pathways within the middle ear while preserving as much kind of natural mucosa as you can within the middle ear space. A big part of that is addressing the tympanic isthmus, which is the space and the kind of the pathway between the eustachian tube middle ear up into the antrum and mastoid, which kind of divides those two into the anterior inferior compartment, the tubotympanic space, and then the posterior superior, the adequoantral. But there's a very narrow space that does go between the cochleariform process and incus, which can provide that aeration between eustachian tube and mastoid. There's secondary pathways, including up in the anterior epitympanum and suprapubic recess, which can be occluded by a tensor fold, which I'll show you in a second. But the thought here being that if there is dysfunction or occlusion of this tympanic isthmus, this can lead to complications related to cholesteatoma. This would be an example of an adequoantral retraction with an aerated middle ear, or tubotympanic, in which the middle ear is covered with effusion and then the cholesteatoma is retracted. A different patient with similar disease, you can see that the anterior middle ear is aerated, cholesteatoma is completely collapsed in posteriorly and in the attic. Perhaps this speaks a little more towards the mucosal traction theory of cholesteatoma, but either way, the cholesteatoma itself and diseased tympanic membrane is removed, head of the malleus and incus are removed, disease from the attic removed, and then the kind of cholesteatoma that's wrapping around the stapes can be resected and pulled off with cup forceps while preserving the chorda tympani to really just kind of expose that full middle ear, restore those ventilation pathways, especially where the tympanic isthmus is, and up into the attic. As I mentioned, one of the blockages can be this tensor fold in the suprapubic recess, or coming down superiorly from Sheehy's cog down to the cochleariform process, which can block the aeration of the attic through the eustachian tube up into the anterior epitympanum. Here's an example of a tensor fold that comes from Sheehy's cog along the tegmen. To block the ventilation pathways, we can lyse that, much like the thought of kind of opening up natural pathways in the ear and natural pathways in the sinus. Is kind of a similar thought process. So how does this apply to the mucosal traction theory, which of course is from Stanford? I think it still applies. So you kind of a different theory that the mucosa itself kind of adheres and through different mechanisms is pulled via traction up into the attic, up into the middle ear. And as we can see on the picture, kind of pulled along the malleus and incus and ossicles there. You know, regardless of how cholesteatoma forms, we do know that it forms from the tympanic membrane. So I do think the endoscope still would apply and still would have good cause to take these out. But it really does speak towards, you know, if endoscopes and microscopes are still getting residual results, more needs to be done. So once the cholesteatoma is out, we can reconstruct the ossicles using a TORP in this case, or PORP, or kind of IS joint reconstruction, as we see some examples. So how are the results and outcomes for endoscopic acquired cholesteatoma, which is a lot harder? Well, we did see that in our series we published back in 2017, the residual disease with acquired cholesteatoma was 11%. And there is good evidence that the endoscopes themselves will find that kind of hidden disease and find that residual disease, whether it be residual disease after the primary resection, as this study is demonstrating that when you think you're done resecting with the microscope, take a look in with the endoscopes, and you very often residual disease will still be found, or finding residual disease during a second look using an angled endoscope to look up into the antrum and find a pearl of disease without doing a mastoidectomy to find that same pearl. So really, the evidence is pointing towards, regardless of how the cholesteatoma is removed, microscope or endoscope, that an endoscope, there is value in putting an endoscope in at the end of the case to look for residual or remnant disease that needs to be removed. So looking at pediatric acquired cholesteatoma in relation to residual disease, a meta-analysis in 2019 is probably the kind of most powerful thing here, most powerful paper that we're going to look at here, which included 6 different series, including ours, and compared endoscopic ear surgery and microscopic ear surgery, and did find that there was a significant odds ratio of finding residual disease with the endoscopes, or I guess another way to say that is having residual disease remaining after microscopic dissection. So the microscopes are more likely to leave residual disease because they just simply can't see quite as well into the nooks and crannies, whereas the endoscopes had a lower rate of having a residual disease when compared to the microscopes in a comparison of 6 different series. When we're looking at recurrent rates, essentially they're the same across 6 or 7 different series in a paper out of 2019, that the recurrent rates for endoscopic and microscopic were essentially equivalent. So what we're seeing is the recurrent rates are equivalent, but there is an advantage for residual disease. Either way, that does speak towards what I was mentioning earlier, that there's more work to be done. Even with the best techniques we have, microscopic, endoscopic, our disease residual and recurrent rates are not 0. And likely work in cholesteatoma will, in the future, will be much more related to delivery of mediators and anti-inflammatory mediators and anti-osteoclastic things to prevent the cholesteatoma from progressing. And there are a lot of other future kind of directions we can go with endoscopic ear surgery. These pictures are an example of one of our fellows did this when she was in residency at CHOP, and did endoscopic ear 3D printed training modules in which the residents can be trained on a 3D printed module. Certainly with the use of curved instruments and powered instruments and instruments in which the tip can be manipulated, these will advance the field of endoscopic ear surgery as well. And augmented reality in the OR, having a picture, having an overlay on the screen of where, you know, ossicles would be or where disease is on the screen in real time during surgery, I believe is in the future. I'm going to wrap it up there. There's plenty more to be said. You know, the World Congress lasts a couple of days worth of talks, and I try to summarize in, I think, 45 minutes here. But I'll wrap it up. And I do want to thank you very much for letting me talk on a topic that I think is really fun and feel strongly about. And yeah, I'm free to welcome any questions or discussion that you may have.
Thank you, Steve. That was wonderful. Thank you for sharing that. I have a question.
Yeah.
I'm wondering, has endoscopic surgery changed you and maybe others? Love to hear from Kay and Ahmed. Your threshold of converting, doing a canal wall down, or do you just try to do more with endoscopic until you give up later?
Yeah, that's a great question. And I think it's not only the endoscopes, but also the patients, frankly, because with pediatric patients, I'd say my threshold for canal wall down is probably higher than it would be in an adult patient. Whether that's correct or not, certainly there's kind of always hope. Well, maybe one more try with the canal wall up. So overall, my canal wall down rates are, I don't know how often I do them, but it is very infrequent. I would estimate maybe less than twice a year, although ironically I've done 2 in the last month. But I would say that with the endoscopes, kind of being able to look around and feel like I've actually seen whether there is any hidden disease and can kind of open up those aeration pathways. Short answer is yes, my threshold is higher for canal wall down. And usually it takes really bad recurrent disease, or frankly, if the attic is either eroded or previously resected, and the ear canal is just not really going to be able to handle it.
Excellent talk, Steve. Enjoyed it very much. Yeah, I think I feel the same way. Our canal wall downs have significantly been reduced over the years. In general, if the mastoid is sclerotic, you could opt to do a canal wall down, and then I also wrote up the technique to basically reconstruct the canal wall down endoscopically. So I think it all depends on the pre-op CT and how much cholesteatoma you have. So if it's a well-pneumatized mastoid, then there's no reason to do a canal wall down. You should open it up and clean the mastoid and get rid of the disease. But I think the endoscopes has really reduced my rate of mastoidectomy over the last 10 years. We're doing it far less now. And I'm doing a mastoidectomy for the extensive disease now. In the past, some people still opening up mastoid just because it's opacified on the CT. But as you showed very well on your video, a lot of these opacifications are thick effusion. And if you open up the antrostomy or the adecotomy, then the mastoid disease really is a medical disease after that. It will clear up.
Yeah.
So, excellent talk.
Yeah, and I think that actually kind of speaks towards the way I approach cholesteatoma now. Is I always start transcanal, see what the disease is doing, meaning see how far it extends, and then there's always in endoscopic ear surgery this threshold of, oh, should I convert to microscope, as if it's a shameful thing. It's not. If the patient needs it, that's fine. But certainly, if you can go transcanal and assess and get everything out, then I do that first. Before committing them to going post-auricular.
Yeah, I would agree. Thanks, Steve, for a great talk. I totally agree with what both Ahmed and Steve said. It's interesting because I have canal wall down patients that I follow my practice for many years, but the vast majority of them were from the first 12 years of my practice. The very small of them were from the last 8 years. And I think my rate of canal wall down has definitely gone down a lot.
Have you been doing endoscopic ears for 8 years?
Steve, are there any technical advances that will allow use of 2 hands?
Yeah, that's a good question. And so one thing that comes up very often is a speculum holder for endoscopic ear surgery, or an endoscope holder rather, so that you can leave the endoscope in and use 2 hands, which it seems nice, but I have to say then you lose that dynamic visualization. And also there may be some risk there if the patient bucks or something like that. But there's actually an advantage to having that endoscope. It's a 2D view, but if you're constantly moving it, then your brain just interprets it as 3D. So short answer is most people who are doing endoscopic ear surgery after the learning curve, frankly, aren't really looking aren't looking to use 2 hands, with the exception of being, certainly there's times I wish I had a 3rd hand, I guess.
Thank you. Great talk, Steve. Very proud of you. Thank you so much.
Thanks.
All right, thanks.
Nice, Steve. Good to see you.
Excellent.
Thanks, everybody.
Appreciate it. Apologize.
Hey, I didn't want to. Oh, sorry.
Oh, go ahead.
Hey, Dr. Hoff, I'm one of the head and neck surgeons here, and I really enjoyed your talk. And I had just a quick question. Does the introduction of this new approach cost a lot of money? And is that controversial at all in the space? Because, I'm involved in robotic surgery, and I'm just curious to see and learn from analogous tech innovations throughout our specialty. Thanks for a great talk.
Thank you. It's a great question, and a couple of points to that. First, it doesn't have to cost a lot, meaning the endoscopes themselves, what I'm currently using are 3mm endoscopes designed for endoscopic ear surgery. That being said, the 4mm sinuscopes work great for almost every patient as well, including pediatric patients. So you can just use the endoscopes, the sinus endoscopes that the hospital already would have. One key thing there is you do want to get the long endoscopes, so the 14cm, which are the same ones you use for sinus, but the temptation is to get a shorter endoscope for ear surgery, but problem there is then your hands bump into each other. Most things can also be done without the specialized endoscopic ear trays, of which there are 3 kind of main companies doing them. Most of the advantages there being that the instruments are curved and some have suction on them. But in general, they're not required. But if they are, it's kind of a single tray. Maybe you want to duplicate it, but it's not a large cost. And then it really just comes down to the learning curve in the OR. So training the OR staff, and then going through the learning curve yourself, as far as your cases are going to be slower at first. But there was actually a study, I think it was Mark Bennett out of Vanderbilt, who produced a study that did say after the learning curve, there's actually about an $800 savings per patient based on less OR time and less postoperative pain medication. So potentially it could save money for the hospital if that argument can be used.
Well, I actually definitely want to make a point about the saving money part. Apparently, endoscopic ear surgery is actually very popular in poorer places in the world, like South America, because it's actually cheaper to have an endoscopic ear surgery set up than to buy an expensive OR microscope. And so, it's not necessarily more expensive. It may actually be cheaper than the alternative.
Yeah, and they're popular on mission trips for that reason too, that you can bring a duffel bag full of endoscopic ear surgeries, ear instruments, and not the microscope. So there's potential there.
Yeah, just a quick comment, Chris. The Leica microscope drape costs about $700. So just not draping, our surgery centers have been very happy with me doing endoscopic cases. We don't open sutures.
That's incredible.
We don't open cautery, no sutures. Surgery in good hands is actually quicker, and anesthesia is shorter. So because they submit a flat charge, an L code and a G code, the surgery centers that I'm involved with, they actually like it a lot, because they get paid the same as if they did an open approach, the same amount, but they saved a lot of money because they didn't open a lot of packs.
Wow.
Remarkable. Thank you.
My recommendation, Steve, if you want to get rich, is develop microscope drapes for $200 or $300. You'll take over the industry and you'll make a large profit.
That's what I'm hearing. Okay.
I mean, it's saran wrap, for God's sakes,
Right. Let's get the innovation center on it. Yeah.
Well, good. Thank you so much. It was a great talk.
All right. Well, thanks, everybody. I hope you have a good night. And yeah, keep your eyes on the polls and stay safe.